Good morning, everyone. I'm Feyza, and it's an honor and a privilege to be here today to talk about a topic that's not only dear to my heart because that's very relevant to what I do on a day-to-day basis in my job, but also a topic that tends to be poorly understood out in the community. Before we start, just a little bit about myself. I am a child and adolescent psychiatrist who was trained in Massachusetts and Vermont. I did my child and adolescent psychiatry fellowship here in UVM. And right now, I see patients in 2 community mental health agency settings. I see Chittenden County patients in Howard Center and Edison County patients in the counseling service of Edison County. And I also am an assistant, clinical assistant professor at UVM, and I have the privilege to teach medical students. That being said, let us start. Please feel free to type in questions, and I will save an additional 10 minutes at the end of the presentation for questions as well. I have no conflict of interest to disclose. That means I take no money or no financial benefits from any drug company or any place. So whatever I say, you can fully trust. All right. So I guess it's a good idea just to start with understanding what trauma means. A traumatic experience, a traumatizing event, will be used interchangeably, but basically it's a threat to the child's life or sense of safety. It could be actual, which is actually happening to the child, or it could be a threat. It could be a threat to the child, even if it's not happening. It could be a threat to the child. I think the most important feature of the actual or the threatened event that's happening is that the child has a response that includes fear, horror, helplessness, and loss of control. It's not a minor thing that's happening in their lives. They do, to be able to call it a trauma or a traumatic experience, the child does have that experience of fear and horror and helplessness, and moreover, the lack of control over what's happening. So that's the umbrella definition of a traumatic experience. That being said, what you and I can read on paper and perceive as trauma could be, nah, that wasn't at all traumatic to me, kind of an experience to the child, whereas something that sounds or feels like, really, that's traumatic to you, could be that child's trauma. So it's important that it's self-identified. It could be as simple as seeing a spider, or something as seemingly bad as I almost died in a car accident could be just not a traumatic experience in that child's self-description. So it's important that whatever the exposure is, it is self-identified by the child. So let's expand more on that. That's the definition, but let's expand more and see what could be some examples of childhood trauma. And I am using the child or the childhood term, but that obviously applies to adults as well. And there are certain things down in the presentation that applies only to children, but this is more pervasive than just children. So the ACE study is a groundbreaking study that was started in 1995 with collaboration between CDC and Kaiser Permanente. And after the study is done, which was basically 17,000 Kaiser Permanente volunteers who gave their personal stories to the study group. But after this study was completed, there were over 50 papers that was published just by analyzing what those volunteers gave to the ACE study recruiters. So that in that regard, this database is a huge database that many researchers after that used. And in the ACE study, they basically asked those 17,000 volunteers about their trauma, self-identified trauma. And it's, I think, a very good sample that can be generalized to the whole United States and to the whole national or whole world experience of trauma. But the number one was physical abuse by the caregiver. Number two was substance abuse in the house, whether it's alcohol or drugs, and the aftermath of that substance use by the caregivers. Loss of a parent, sexual abuse, mental illness in home, whether it's, again, primarily when it's a child, it's mainly a caregiver, mom or dad, having or struggling with a mental illness that's not treated, or it could be a sibling that affects the dynamics in the house as well. Emotional neglect, mother, and it's interesting that it's excluding the fathers as if they don't play a big role in a child's upbringing. But interesting enough, most of the volunteers said mother, treating the child violently. Psychological abuse, emotional abuse is sometimes what it's called. Physical neglect, and somebody in the house being incarcerated, going to jail for whatever reason. And again, it's not only the fact that mom or dad is going to jail, but what was going on before that and then the deprivation after that. So those appear to be the most commonly encountered traumatic experiences. Here's another study called the Great Smoky Mountains Study. This was done in North Carolina, and about 1,500 children were recruited for this study. And in this group of children, almost 70% of them had one of these: child maltreatment, domestic violence, traffic injury, basically motor vehicle accidents, medical trauma, meaning either being diagnosed with a medical condition or having had something happen to them that required an intense medical treatment. Traumatic loss of a significant other, primarily caregivers, and again, sexual assault that also came up in the ACE study. Other examples that did not come up in ACE or Great Smoky Mountains study are neighborhood violence. Definitely living in places where crime rates are high is a huge risk factor for being traumatized. Torture, natural disasters, which Vermont went through a few years back with the flooding, man-made disasters. I think this could be a good time to just take a few seconds to acknowledge what's going on in our world nowadays. In France, in Middle East, speaking of natural disasters, the earthquake that happened in Japan last week, I guess just listening to NPR on the way to work is enough to be experiencing secondary trauma. But I'll take this opportunity to acknowledge and send my thoughts to all the people who are going through very, very traumatic experiences nowadays in our world. But natural disasters and man-made disasters, although they seem to be more rare, they are huge. Bullying, maternal stress during pregnancy. This is something that tends to be not ignored, but maybe even forgotten or not necessarily perceived as, really, is that traumatic? Is that your trauma? But it certainly is. And I'll tell you which kind of studies and research that information comes from down the talk. But even if the baby is in the womb and mom is stressed out, or mom is using a substance or drinking, or mom is being abused by the partner, even that impacts that developing brain significantly. And we definitely see the sequela of those experiences once the baby is out in Earth. Oh wow, I tapped bullying twice here. I'm just noticing, so just ignore that. Um, Poverty, food insecurity, and then homelessness are other examples. So there's a question coming in. It's are these statistics similar to what we would find in Vermont? And the answer is yes. Actually, I can send the exact numbers of statistics for the interested audience. But as I said, both the ACE and the Great Smoky Mountains study are very generalizable, and that applies to Vermont as well. Vermont is kind of starting to be unique for the past decade, that the substance use rates, especially heroin, is starting to increase. We're starting to see more and more of substance use related trauma in Vermont. Vermont is also unique in that, especially in Chittenden County, with the refugee resettlement programs, with all the Somalian, Bhutanese, Bosnian parents that we now have, the new Americans that we have in Burlington, or Winooski in Chittenden County, basically. We also have the new Americans that have the types of examples that are more rare to encounter are more relevant to Vermont, such as torture, man-made disasters, or poverty, food insecurity. Those seem to apply a little bit more to the Chittenden County than maybe elsewhere in America, just because of the fact that we have refugee resettlement programs. However, otherwise, it's pretty similar. And if you're interested in the exact statistics, I can absolutely send you those numbers later this week. Actually, the next slide could be answering the question further. So this is the 2013 data from Vermont DCF website. Actually, in 2013, there was a record number of calls to the Child Protection Line in Vermont. 17,458 calls were made. 72 of those calls were made by mandated reporters. 19 were non-mandated reporters, and 9% were anonymous. So I'm not quite sure who my audience right now listening to me is, but by mandated reporters, there is a group of individuals who are in professions that are in direct touch with children, such as physicians, teachers, daycare providers, that are they have to report, otherwise their licenses will be revoked. But you don't have to be a mandated reporter, and if you're even suspecting, even if you don't have enough evidence or data to prove that a child is being maltreated, you still can report, and there will be no retaliation or consequences to that, because as you even see in the statistics, you can even anonymously report. So all of those above 17,000 reports, 5,135 of them were accepted for intervention, and actually 790 cases were opened for ongoing services. And the services were either there is a high risk of future maltreatment, so we have to support this family, versus it's happening right now, so we have to make more strict interventions and make sure the child is safe. And substance abuse was a factor in almost 30% of the reports that were received in Vermont. Financial stress was relevant in 15% of the reports. Domestic violence and mental health issues, again, in over 10% of the reports. So as you can see here as well, The Vermont data is very similar to ACE study and Great Smoky Mountains data. Just want to make sure, again, for the audience that's there right now who are not professionals, this is a copy-paste slide from the Vermont DCF website, and this is the number that you can call 24 hours a day and 7 days a week to report, even if you're not sure, even if you don't have the evidence, but you suspect that a child is being abused or neglected. It's then their job to explore and make sure the child is safe. All right, so let's talk more about, now we have the definition of trauma and some examples of those traumatic experiences, and let's expand more on that. We identify trauma, or we classify rather, trauma as type 1 or type 2. And type 1 trauma would be one event that's single, that occurred once, it's well defined by the child, and from there on it never happened again. Whereas type 2 is it happened over and over, multiple times in a sequential way, and it was kept secret by the child, whether the perpetrator was threatening or the child just couldn't understand even that was a bad thing that was happening to the child, but it kept happening over and over. And if it's not something particular that's happening to the child over and over, it could be a chronic neglect situation, or chronic homelessness or instability, or chronic poverty. But the point is, it's not like a one-time thing that happened to me. It's not the irony that happened and it's over now and there is no irony anymore. It's happening over and over in my life. It could be maltreatment, it could be sexual abuse. But again, type 1 is once and well-defined, and then type 2 is more chronic. Why is this important? Type 1 tends to cause, if it's going to cause, PTSD, and I'll expand on that in the next slide. And type 2 seems to cause more complex trauma. And let's expand on those two terms and let me help you understand what those mean. So if one thing happened to you or your child, it may turn, it may not, it doesn't have to. And I'll again talk about why in some kids it does turn into post-traumatic stress disorder and why some kids don't have that, although they do have a traumatic experience. But type 1 trauma typically tends to produce PTSD. How do we recognize PTSD? What does that even mean? We use that term as many other psychiatric diagnoses like depression or bipolar. Out in the street, those terms tend to be used. Oh, I'm so moody, I must be bipolar. Or, oh, it's such a bad day, I feel so depressed, it's gloomy, it's raining. Well, bipolar or depression means really something else clinically. Just like that, PTSD sometimes tends to be used without quite understanding what it really clinically entitles. And here's what it entitles. I like to think about PTSD symptoms in 4 categories. And the first category is the intrusive symptoms. The traumatic experience and the memories from that experience intrude your days or your nights. When you're awake, you tend to have flashbacks about them, or when you're asleep, you tend to have nightmares about them. Avoidance symptoms is the second cluster. You try to avoid as hard as you can, whether it's the memories or the thoughts about it or the reminders. And the reminder could be, this is where I had the car accident, so I'm just never going to drive through that street again. Or this is the daycare that I was abused, so I can't even, see daycares or walk past that daycare because it just floods me with the memories of what happened in that daycare. A reminder could be a smell. This is where I was abused, and that's exactly how it smelled in that basement. So it could be anything that reminds you of the experience, and you want to avoid that reminder in your best ability. And then mood symptoms. You either withdraw or you start feeling down. Well, if I hadn't done that, then he wouldn't have beaten me up. Kind of self-blame, which is very common, or just no joy in life anymore. Life just sucks. I have no more interest in any of the things that I used to get pleasure from. And sometimes our minds tend to block out. That's a good defense mechanism to protect our sanity. And sometimes people tend not to remember what had happened to them. And then the hyperarousal symptoms is the one that people get more confused about. And the child becomes aggressive and self-destructive, biting self, banging his head, or vigilant and paranoid about friends. And I can drop a pen and he goes, that exaggerated startle and can't focus. Oh, do they have ADHD? Or they pay no attention and they can't sleep. The acting out, the externalizing child that gets labeled as the naughty kid if the caregivers or the educators are not aware of the trauma background and the child is just acting out and disrupting the whole environment. Those are some sad cases that we need to be really trauma informed about, and they're just not naughty kids, they are traumatized kids. And then this is the one that is more caused by chronic trauma. The picture that you see in the screen is a guy called Bessel van der Kolk, very well known. You can Google him, buy his books, or even watch his videos on YouTube. He actually is the guy who feels very strongly about EMDR. We'll talk about what EMDR is in the treatment section. But he came up with this idea that PTSD is a big diagnosis and it has certain criteria, but if you had chronic trauma, you may not necessarily meet these criteria, but you're still traumatized, and we don't even have a diagnosis for that. So why don't we come up with this developmental trauma disorder diagnosis? And unfortunately, it didn't make its way to the new DSM-5. DSM is our book, if you will, that committees come together to put together the diagnostic criteria for psychiatric disorders. And the new DSM just came up in May of last year, May of 2014. But unfortunately, developmental trauma disorder didn't make its way to DSM-5. What Dr. van der Kolk argued was that children with chronic trauma do not necessarily have PTSD, but they have so many problems that we have to have a title for those kids. And he argued that that name could be developmental trauma disorder. For the sake of it being more easy to say and easy to remember, I'll use complex trauma for this disorder. And it's basically chronically traumatized kids who don't really fit in the PTSD category, but they are struggling in many ways. And these are the three main categories of symptoms that these complex trauma kids struggle with. They have significant problems with regulating their affect, meaning their emotions and reactions. So affective and psychological dysregulation. They have struggles with regulating their attention and behaviors. That's why they're commonly labeled to have attention deficit and hyperactivity disorder, ADHD. Whereas they really don't have ADHD, but they have complex trauma, and they have significant struggles with self, meaning how they perceive themselves in the world, and relational dysregulation, meaning how to regulate their interpersonal relationships with peers, friends, family members, or adults. And we'll expand on all these. And it doesn't mean that they don't have They can't have the PTSD symptoms that we talked about here. They can have all those 3 plus PTSD symptoms, but that's more rare in a child who's 4-year-old, who is acting out, biting his arms, kicking peers, not learning, not paying attention, and he or she doesn't necessarily have nightmares or flashbacks or trying to avoid memories or, you know, these symptoms that you see in the PTSD slide, but they are just so dysregulated and then labeled as the naughty kid or the ADHD kid, whereas this is really complex trauma. And the importance of this is that the acting out do cause functional impairment. They do fail in school. The family is distraught because they can't even go to a grocery store shopping without having an incident, or they can't make friends, or sometimes even they're in legal trouble because they were busted with weed in their backpack, or they just shoplifted from Rite Aid, something like that, if they're more in the adolescent age group. But complex trauma kids, I like the quote that the kids who are in most need of love seek the love in the most unlovable ways. So they are the kids that need our nurturing and attention the most, but they're just so dysregulated that sometimes they are even hard to like in the moment. But the complex trauma with what they went through, unfortunately, in their life just doesn't allow them to be what they're supposed to be like. So I hope we have a nice understanding of what trauma is and what the symptoms look like. Let's see how those kids, we talked about more like criteria to make diagnoses, but let's see how on a day-to-day basis those kids really look like in a classroom or in a family setting or at the church, or what do those kids like act like or present as is now what we're going to talk about a little bit. Typically, what brings up that complex trauma symptoms in them is what we call a trigger. The real world is already kind of down and sad, and once you bring a trigger in that world, then the child enters this alternative world that they go into, and it's not a nice place to be. What's the trigger? It and we're going to talk more about triggers, but what's happening to them, it's so subconscious usually. They most often can't even identify what just happened. What just happened? Why did I just kick my friend? Why am I screaming for the last half an hour? It's typically, especially with younger kids, it's typically a very subconscious response to the trigger. And there may really not be a real trigger. There may not be a danger or a provocation or really nothing is going on, but their world is so fragile that they may be triggered with something that's not at all actually a trigger to a child who has not gone through a traumatic experience. So what are the common triggers? For kids whose trauma is violence, whether it's domestic violence or physical abuse, seeing people argue or being loud or even somebody disagreeing with them could be a trigger. So I wanted to play with my Legos, but my friend just was in the mood for Play-Doh. You know what? I'm going to kick you. So what does the daycare provider or the kindergarten teacher see that as? Oh my God, just play with the Legos. Just play with the Legos. Why did you just kick your friend? But what's happening in that child's subconscious is that this is what happens at home every day. Mom argues with dad over something subtle and then dad beats mom up, right? So their subconscious being triggered immediately goes to those acting out places. And then the outside world just sees it as the bad kid, very unfortunately. For kids who are neglected, being alone could be a trigger. For kids who are abused in emotional ways or physical ways, just simple limit setting. Nope, you have to You have half an hour to dinner, so it may not be a good idea to have M&Ms right now. After you have your dinner, I'll let you have your M&Ms. Just as simple. Like this simple limit setting could be a trigger. And they're not throwing a tantrum over M&Ms. Their subconscious is being triggered. And I'll tell you how that happens in the brain biologically in just a second. For kids who have been abandoned or neglected for years, even good things trigger them. This friend is being really friendly with me. I never had this before. I don't really know how to be a good friend. I don't know what to do with this feeling. So you know what? I'm just going to do something to sabotage the friendship. Or I'm now in a foster parent setting, foster care, and this foster mom is reading me a book and stroking my hair before bedtime and giving me good night hugs. I never had that before. That's weird. Do I even trust this woman? So I'm going to act out. So even positive relationships, as confusing as it may sound, could be a trigger for especially kids who were abandoned or neglected. For kids who were raised up in chaotic households, any kind of lack of structure or consistency could be triggering. Again, things that seem to be very, very simple and seamless. For example, my second grade teacher is under the weather and called out sick, so there's a sub. And what we do every day in second grade is we color in the morning to settle in the classroom before math time, but the sub doesn't know about this, so we skipped coloring. That simple thing could be a trigger. A change in their structure or change in their consistency even could be triggering. Because, excuse me, the chaotic upbringing is what drilled into this is what it drilled in their brains. Again, any reminder of the traumatic experiences could be a trigger. That's an obvious one. I was abandoned by my mom right after Thanksgiving. So whenever it's the turkey time, the smell of the craisin sauce with the craisin and orange sauce, every Thanksgiving is a scene now. Because that's a reminder of the trauma, and those are more obvious triggers. And then, of course, any lack of the basic need of a child, like sleep deprivation, tiredness, feeling cold or hot, hungry, or just scared or nervous about something, could be a trigger. And sometimes they're not even able to identify and say, this spelling test makes me nervous, so I don't know what to do with this. It sounds very simple, right? But the 6-year-old, for example, would not be able to do that, and he would trash the classroom, or he would throw a tantrum in the house. So again, it's sometimes observing and trying to catch those patterns to understand the triggers, because they're not necessarily going to be able to identify it themselves. And then what's not very uncommon is also that it's very unpredictable. What could be a trigger this day could not be at all a trigger the other day. And then sometimes it's hard to find a rhyme or reason to what could be triggering a traumatized child. So let's take a break from symptoms and let's just step out of the trauma world and get into our skulls a little bit, and let's try to understand the brain. So rather than pulling up fancy anatomical slides, I thought this could be a more visual and simple way of learning about the brain, which is like a miracle organ. And we know so little about in spite of the advanced technology. But the simplest way I could explain what I want to explain to you felt like this Lego slide. So the brain has 4 very important parts to it. And I'll tell you why this is relevant. Why do you need to learn about brain? I'll tell you why in just a second. So the brain stem is the most what's the word? Like even a reptile has that part of the brain. Even the ant walking with a crumb in his mouth has that part of the brain. Like the most underdeveloped and primitive part of the brain. And it's responsible for the basic survival functions, like my blood pressure is okay, my heart is pumping at just the right pace. My body temperature is exactly where it's supposed to be, like the survival brain. I sleep at night, I wake up in the morning, I'm hungry, and when I eat, I feel full, like basic survival stuff. The most primitive animals have this part of the brain. Every single living creature have this part of the brain stem, right? And then the layer above um, is brainstem and the midbrain work together for the survival brain. And then the part above is the limbic brain. In the limbic system, amygdala is the part that's in the limbic system that is basically our feeling brain, our emotional brain. So that part of the brain handles, manages, regulates all kinds of emotions that we may experience, whether it's a pleasant or an unpleasant emotion. So we have the survival brain, then we have the feeling brain, and then on top of it, which is the most developed in human beings actually, is the cortex, which is our thinking brain. So the thinking brain, the cortex, it's basically the juicy part of the brain right behind our foreheads, the frontal lobe. It's almost like the CEO of your brain. It's the part of the brain that gets the information, analyzes it, puts it out as behaviors, pays attention, keeps the memory, processes the information, organizes. It's the CEO of the brain. So I survive and I feel and I think as a human being. And that applies to the child. What's amazing about the human brain is it completes the maturation of all the way from that brainstem to full-blown matured cortex in over 24 years. Average male brain completes the maturation in 27, and average female brain completes the maturation in 24 years. These are some functional MRI views that shows how, and the bluer, if you will, the more mature, because certain parts of the brain gets what we call pruned, and it gets thinner and thinner, and they make connections in between different parts of the brain. The neurons kind of get revived, and some of them gets pruned, and they make connections between different parts of the brain. And all that process gets completed all the way up to almost 30 years old. So can you imagine what kind of a moving target a child's brain is? And can you imagine when that brain is desperately trying to develop and learn and get from the brainstem, the surviving brain of an infant, to the thinking and analyzing and processing and organizing brain of a teenager or a young adult? Can you imagine if you disrupt that crucial process with a horrible thing that happens to you? We now know with the advanced technology that it's not like just we're guessing that that's what happened to the brain. We can now see it. We can put kids in functional MRIs that light up right in front of your eyes in the machine, that certain parts of the brain that's like thriving to develop just stops lighting up. It's really sad to see. But science is as a brain, as amazing as the brain is, so is science, and it now shows us that those critically important stages of development is disrupted significantly when you have a traumatic experience. So what happens then? What happens is the thinking brain almost checks out. And that survival brain, the yellow block down there, takes over. So the child goes from, oh, okay, my friend looked at me weirdly. Maybe he's having a bad day. I don't know, maybe I said something wrong. Should I just go and apologize? Well, no, let me think about this. So thinking and processing and putting out the behavior, that thinking brain checks out, and the child starts functioning at the brainstem level. Oh, my friend looked at me the wrong way. Oh, he's going to hit me. You know what? Before he does that, I'm going to go hit him. So it switches to the survival mode. I am, let's say I'm going through chronic neglect, so I'm hungry most of the day. So, oh, there is this snack basket in my classroom. So if I can just grab a couple of granola bars there and hide it in my backpack, that's going to be my food, right? The survival brain took over. So what does that sometimes look like from an outsider? Oh, the child is stealing. No, the brainstem took over and the thinking brain checked out because the brainstem is trying to survive. He's not, yes, technically it's stealing, but he's not really stealing, he's trying to survive, if that makes sense. So a couple of examples how the thinking brain checks out and the survival brain takes over in a traumatized child. Other ways how the brain stem, meaning the surviving brain, takes over is nicely, again, categorized in 4 Fs. Fight, flight, freeze, or flock. Fight, I gave several examples. They tend to act out. Flight, traumatized kids tend to run away or bolt. Or they flight in an internalizing way and they just disconnect from the outside world emotionally. Or they can just freeze, they just stop functioning. Or they can flock, meaning they tend to be with friends who are similar, that they can identify with, and that sometimes can form unhealthy relationships. But the more that arousal of the survival brain increases, the more the cognitive ability, the thinking brain, checks out, and the function of that part of the brain decreases. And once they're in that fight or flight mode, you just forget about talking them out of it. They can't be reasoned with, whether it's a tantrum or screaming for 20 minutes or it's running away. Just you cannot necessarily reason with them. They just need help in different ways. So how do we help them? How can we approach these children? Now we understand what they're going through, but how are we going to help them? ARC, I probably should have made it more clear, but A for attachment, R for regulation, and C for competency. ARC is a well-known and applied approach for these traumatized children. So you work on their attachment, meaning how they're going to relate to their caregivers now who are safe, how they're going to regulate themselves, and how they're going to calm down the survival brain and bring in the thinking brain back. And then competency is how are they going to catch up with the delays in their development, and how are they going to start feeling good about themselves by achieving their age appropriate life goals. So some of the things, so ARC is the model that we work on, and these are the things that applies. You work on the attachment by saying, yes, you have all kinds of right reasons to mistrust the world, but guess what? There are safe people around you, and the world can be a safe place. Making sure that they do get into their social world and they make those friendships and they keep those friendships and they understand the cues from friends or adults in the right way without going into that survival mode. Recognizing their emotions. Again, it's so hard for, let's say, a 7-year-old when mom, who should be the safe haven, right? It's mom, and mom is abusing me, or mom is not available, or mom is hanging out with the wrong crowd, or mom is just sleeping on the couch all day long because she has untreated depression. It's not only very confusing to them, but also it's hard to recognize what's going on in them. So recognizing their emotions and then managing their emotions. And then if they're moving between emotions really fast, from sad to angry to happy and then to angry again, very fast with no reason, let's not call them bipolar. They're traumatized, and let's help them and their caregivers understand what this is all about. The intensity of the emotions. So again, did you just throw a tantrum over M&Ms? But this is what's happening. This is why the survival brain and how the survival brain kicks in. Difficulty self-soothing. So help them find things that could be helpful to calm themselves down. Are you going to count? Are you going to listen to music? Are you going to take a hot shower? Impulse control. Again, they tend to run away or bolt. How are we going to stop and think and recognize what's going on and do something about it? Aggression, defiance, the externalizing behavior, or sadness, anxiety, shame, guilt, fear, hopelessness, all the internalizing feelings that are very commonly encountered in these children. And again, the competency piece. So we worked on and this is hard work, and this is not going to happen overnight, obviously. So attachment, the world is a safe place, can be a safe place. And then regulating the emotions, the R of the arc. And then C, the competency is, all right, now I know what's happening to me. I'm in a safe place, and I understand why I'm going through what I went through. Now it's time to plan and organize and learn and get back on track. And I'm going to feel competent again. So I will switch from the victim to the survivor mode. And that only can be done by being back to competent. I'm going to boost up my self-esteem. And that's how I'm going to feel good about myself. And these kids typically do not like being praised whether it's in the middle of their trauma or still working on their trauma. Some kids just reject praise, or once you praise them, the next minute, before you know, they do something to sabotage it because they're just so not used to being, in quote, the good kid. And then also, if again, because their development is very much disrupted, to catch up on any delays, if they need PTOT, meaning physical therapy, occupational therapy, to catch up on their motor skills, or their writing is behind, or their learning is behind. So to make sure that their developmental delays are worked on. So that's the ARC model that the professionals work on. What else could we do? Again, basically repeating the same things, but to establish a safe environment, making sure that we understand and avoid the triggers. Managing our own affect is, I think, very critical. It's, if I am taking care of a traumatized child, or if a teacher is taking or trying to teach a traumatized kid, they can be extremely triggering to the caregiver. So taking a deep breath and saying, I know where this child is coming from. As hard as it is to manage this child, I know where this child is coming from. Just to have a lot of patience and compassion, to be able to still take care of that child. So whether you need your own therapist to manage your own affect, or you need your own professional support, because these are tricky kids to raise, but managing your own affect as the caregiver is extremely important. Identifying the strengths of the child and building upon them, rather than, okay, you're acting out, your learning path is behind, you need some dental care because you were, all the problems. Sure, we're going to take care of them, but also identifying the strengths and then building upon them with realistic outcome goals. Yes, you're 3 years behind, but now we're going to have you read this level of a book because you're 9 years old and you should be able to. No, let's take a step back and meet the kid where he is at and make some realistic expectations to set them up for success rather than having them fail and then feel bad about themselves. So make sure that the competency, the C4 arc, happens. Accommodating schoolwork, modeling healthy behaviors over and over. Again, these are not changes that are going to come overnight, and passion and patience is critical when you're taking care of a child with trauma background. Providing choices rather than control, because they again, remember, go back all the way to the first slide, they have that sense of, I have no control over what's happening to me. So then they pull you into power struggles because they want to be in control now that the world seems to be safer. So give them choices rather than saying, this is what you're having for dinner. No, would you rather have this or that? So it just it helps with the boosting the self-esteem, and that helps listeners feel less and less and less. And they will slip and they will fail. And then are we going to punish them, or are we going to help them understand what just happened and then logical consequences to repair what they did rather than punishing for what they did? Let's write a card to your aide that you just kicked because this is what happened. But guess what? We can just move on and you can learn from this experience. So the consequences, nurturing doesn't mean they can't be disciplined, but the discipline should be more towards repair than punishment. And helping modulate their emotions, as we talked in detail. So there are many questions that are coming up. If the parent also has complex trauma, should we begin helping the child and the parent, and how well do we do that? So yes, I personally take pride in treating families rather than the child, the index patient. It's extremely, extremely important that the parents first understand their own issues and get their own help. Again, going back to that second sentence in this slide of managing their own affect. It's impossible if the mom or the dad do not take care of their own issues and, giving care to a child that's not easy. So it could start with a good assessment of what, and it's not only if the parent has complex trauma, but if the parent has depression, if the parent has anxiety, if the parent has something that's totally irrelevant. Let's have diabetes and he's already struggling with the medical care. But overall, whatever the child's caregiver, and the caregiver could be a grandparent because mom is in rehab. Whoever the caregiver is should definitely be wrapped up with all kinds of support, psychoeducation, parent management training, treatment of their own conditions, to be able to help these kids. In an ideal world, we should have parent clinics everywhere, but I know that sometimes the system doesn't allow us to do that in the best way that we wish we could. For the sake of time, I'm going to skip this slide. This is a study that tells very briefly about how there is a breed of mice that are very nurturing, and there's another breed of mice that are just very ignorant just by the way they are. That's just how they are. And they took, in this particular study, they took the pups of the mice, that what we call the ignorant ones, if you say, and they gave it, after being raised by their original moms, they gave it to high licking and grooming pups. Those are the mice that just licks and grooms, licks and grooms, licks and grooms the pups. It's just cute to watch. And they just showed that the pups stopped behaving recklessly or vigilantly, and after being with those other pups that had high licking grooming qualities, they just came back to normal and their survival brain kind of calmed down a little bit. And that speaks to how that attachment piece to at least one caregiver is very important in the healing of these kids. And why are some kids vulnerable and why are some resilient? Resilient means, they sometimes bounce back. They adapt to stress and whatever adversity that they face, they just have the ability to bounce back. And there's a lot of research going on about understanding what makes a child vulnerable and what makes a child resilient, that they can quickly or quicker switch from the victim mode to the survivor mode. And it's those little check marks that kind of summarize it. Emotional awareness, again, understanding why they are the way they are. The locus of control, meaning controlling their lives, is coming from internal, not from external. So they do have that strong sense of self to say, this is what happened to me, but this is how I'm going to work on it, and this is how I'm going to move on. So by temperament, they have their internal locus of control. Support from at least one highly licking and grooming adult, if you will, to the analogy to the mice. So one person, it could be a janitor at school, it could be a teacher, it could be a grandma, but at least one person that supports that child. Sense of humor, putting what they went through into perspective to say, I'm not the only one. There are others going through this. Let me see how they do it. Let me see how they survive. Spirituality, high intelligence seems to be a protective factor. Ethnic pride, I'm proud of my roots, and this is how my family did it, and this is how I'm going to do it. This is all coming from research, by the way. And again, over and over, being successful in various areas of their life, that builds up that competency, whether it's an athletic success or a friendship success, but being successful over and over. And resilience is now proven to be, you're not born resilient. It's a trait that you work on, and you kind of become resilient by working on these. And it doesn't mean that resilient people are just free from negative emotions and they're just strong people who are Pollyannas and they could be optimistic no matter what happens. No, they do have emotions and they do go through all those emotions. They just seem to be having the qualities that help them bounce back quicker. The evidence-based, which means the treatment that has evidence towards this is a helpful treatment proven by scientific research, is what we called trauma-focused cognitive behavioral therapy. And this, the treatment is combination of therapy and medications. And the evidence-based therapy entitles these titles. It's a busy slide, but it basically goes back to the ARC model. Psychoeducation, meaning teaching them why what they're going through is happening. Psychoeducation both to the child and the parent. Relaxation skills, meaning whether it's yoga or mindfulness or something that when you're going to that intense triggered place, how you're going to bounce back and relax. Affect modulation, we talked about this. Cognitive coping, how am I going to cope with my thoughts? Trauma narrative, I need to talk about this and get it off my chest when I'm ready. How I'm going to deal with the reminders, and then bringing the parent back in the session and putting them together to form that relationship, and then enhancing safety and development. That's the steps that's followed through in trauma therapy. And then medications do help. There is no medication that's the treatment, like the treatment for trauma. But what we typically do is to symptom target, whether it's this child seems to be responding with high anxiety, so could use an anxiety medication, or this child seems to be really having hard time focusing. So although we know that this is not necessarily ADHD, can we help them with an ADHD medication to help them focus so they can be more successful at that competency piece of the ARC treatment. So we target the symptoms, if you will, with medications, but we don't necessarily have a medication that's proven to be specifically helpful for trauma. So that's the treatment piece. I will end here and I will leave space for questions, which I have one already. So the question is, what are your thoughts on explaining to a child about his or her complex trauma? At what age might you do this? The new documentary Paper Tigers highlights an alternative high school program in Washington State that is a trauma-informed approach, including talking to the kids about their ACEs. I'm not familiar with that particular program. I'll definitely look into it. But going back to the slide, if you will, it really is the age, and more than the age, the developmental stage of the child that allows you to talk to the child. And when the readiness is there is, I would say, when you do that. And as you see the outlines of how we formally do trauma treatment, before you come to the T, the trauma narrative, meaning let's talk about what happened to you, before you even get there, right? As you see, there are 4 steps that could take months actually. You have to provide the education to the child. You have to make sure that he or she now is in a safe place. You have to make sure that he knows how to relax. Well, to identify, understand, and relax when he's in that place. Now that he's ready, now I can talk about the trauma. But in the moment, how to explain why your mom kept beating you, or why your dad isn't available and drunk all the time, or why you're being bullied, or why you had to lose your hair due to this weird lymphoma again? What is lymphoma? So what are you going through? So it really depends on the child's developmental stage to find an age-appropriate language, to use therapy support. There are books that are like literally storybooks that could help. Professionals could help. But making sure that the child is ready to talk about the trauma, I think, is the essential information here, rather than this is the right age. It's very customized, individualized to the child. Is all emotions result to trauma? I'm having a hard time understanding. Would you please retype that question? What's typed here right now is all emotions result to trauma? I will skip that until it's retyped and I'll answer the next question and I'll come back to it. Does the age at what complex trauma occur affect the outcome? So yes, remember how I talked about vulnerability versus resiliency? We know that age is a factor in this, and the younger seems to be the most vulnerable, just as if it's coming from nature and it's, it's again the flooding or the earthquake, it seems to be easier to bounce back regardless of the age, but it's coming from your mom who's supposed to be your caregiver. It's very confusing. So age and the nature of the trauma seems to be 2 big factors that makes you vulnerable versus resilient, among other factors. But yes, the younger the trauma happens and the more ongoing the trauma occurs, the more vulnerable to developing complex trauma the child will be. How important is the caregiver's reaction to traumatic events to the child developing PTSD? Very important. So as you see, the PTSD is post-traumatic stress disorder, and it's theoretically preventable. What you first go through is what we call acute stress reaction, and that goes on for a while, at least a month. And then we do start calling it post-traumatic stress disorder, and with good support, with of course therapy and meds too if needed, but mostly by the caregiver, it is preventable by that. Again, going back, I really, really love that study. I wish we had the time to talk more about that, but it is very important that the caregivers understand and support the child, to not only calm down and promote success, but also prevent PTSD from happening. It's very pertinent nowadays. How are we going to talk about what's going on in France right now to our children, right? I think, again, talking about it in a very calm way, the more the parents are dysregulated, the more or the bigger the trauma will be perceived by the child. So being calm, the question is specifically about Paris, what's going on sadly in Paris, but one, basically preventing the child from being exposed to some violent content as much as we can. So it may not be a good idea to watch the CNN news with the scenes. So to prevent the exposure, and then to sit down and talk with them, to one, reassure that we're safe here. Two, there are some bad things happening in the world, but these are our values, and these are the ways that we can fight back to some of the bad choices people make by being generous, being loving, and being nice. And again, this is a preschool conversation, and it could get more and more sophisticated depending on the kid's age, but basically controlling your reactions and then preventing the exposure to vulgar content, I think, is the first step, I would say. Can you comment on new studies that indicate that kids who have been abused, neglected early in life, but then it ends for the rest of their lives, still have poorer health outcomes later in life? Yes, and those, yes. So that was one of the, remember how I said when the ACE study brought down the statistical data, those studies were that study was followed up with many others, and some of those studies do come from medical fields, not psychiatric medical, but physical medical fields, and we know that early childhood trauma do increase the risk of diabetes, high blood pressure, cardiac conditions, um, cancer. And why that happens is that the research shows that that survival brain, to be able to go back to caveman, right? They had to survive. So they had to have high levels of cortisol and adrenaline in their system to be alert all the time, right? So if that gets activated, if that system gets activated in early ages over and over and over, the brain changes in a way that high cortisol levels do not get suppressed enough, and that's the reason why it starts taking a toll on your physical health. And that's how you start getting the outcomes, even if you're in a safe situation starting from, I don't know, 20 to 30, you can still have some medical poor outcomes, such as the ones I listed, in later in your lives, because that survival brain gets activated and releases certain hormones that do take a toll on your body after in your life. I really don't want to ignore that question that I'm having a hard time understanding. Is all emotions result to trauma? Can we go back to that question, please? And can we clarify that? I really don't want to ignore a question. Okay. So I'll wait for a few more seconds for further questions or the clarification of this particular question. Is all emotions result to trauma? Can you let me know? All right. Okay, so I will get the question later because sounds like he's one of our staff members. All right, thank you for joining us today for the webinar. This webinar will be archived on Vermont Family Network's website along with many other previously recorded webinars. Be sure to visit Vermont Family Network's website at www.vermontfamilynetwork.org for a complete list of upcoming webinars, workshops, and support groups. For support and information, please call us at 1-800-800-4005 and have a great day. Thank you.